اهلا بيكم جميعا. بالنيابه عن جمعيه الشبكيه برحب بيكم في البرنامج اليومي الجديد رمضان ديلي ريتنا ريسيبي شبكيه اليوم. في البرنامج النهارده هنقدم وجبه دسمه في احد موضوعات الشبكيه كالمعتاد، والوصفه السحريه لعلاجها او تشخيصها. وهنتعرف عن قرب على ضيفنا العزيز الصديق العزيز دكتور منصف خيرالله من تونس. دكتور منصف استاذ طب وجراحه العيون جامعه المونستير ومستشفى فاطمه بورقيبه الجامعي في تونس. دكتور منصف احد العلامات البارزه في مجاله ومرجعيه عالميه في مرض بهشت ويوفيايتس ازهور، ووجه مشرق ومشرف للطب العربي عالميا، له اكثر من 230 peer reviewed paper، وحقيقه حجه في مجاله، وهو صديق قديم لجمعيه الشبكيه المصريه. واذكر محاضراته الرائعه من كام سنه اللي الحقيقه اتحفنا بيها، ونرجو ان هي ان شاء الله تتكرر قريبا. اهلا بيك دكتور منصف، اهلا بيك.
شكرا جزيلا. I would like to thank you very much, Professor Mahmoud Suleiman, and I would like to extend my thanks to all the members of the Egyptian Veterinary Society for this kind invitation to participate in the society Ramadan activities and to speak today. I'm very pleased and honored to be.
لا ده شرف لينا. It's our honor, دكتور منصف. Our honor. Did you dream of being a doctor? يعني how did it start of being a doctor?
I was born in a small city in the middle of the east coast of Tunisia. This is a small city called Tebulba, which is located near Monastir, and primary school in my native town, secondary school in Sousse, and I graduated from the Faculty of Medicine of Sousse in Tunisia. And I was very happy to complete my residency training in ophthalmology, and ophthalmology was a dream to me. And I completed my residency training in Tunisia and a retina fellowship in Paris, Hôpital 15 in France. And I was very lucky to be ophthalmologist, because I think this is a very wonderful specialty.
So you had this dream of being an ophthalmologist since a very early age.
Yes, of course. Yes.
Okay, so you had a very excellent, a very special training in 15, which is an excellent hospital in France.
2 years in 15 in the Department of Ophthalmology, led by Professor Jean Ho in Paris a long time ago. And I was very interested in retina and in medical retina, surgical retina, and in uveitis. And I started. Yes, please.
Yes. Did you actually think of emigrating to France at one time?
Never. I think that I had to serve my country, and I think I'm very lucky to work in Tunisia, and particularly in the University Hospital in Monastir in Tunisia. I started my professional career in this department in Monastir as a consultant, and I became assistant professor and then professor and chair of the Department of Ophthalmology.
Well said, Dr. Monsef. Well said. Yeah, we have to serve our country, don't we?
Yes, of course. And
okay, so you started. I mean, how did you end up in uveitis?
I think that I started with the medical retina, and then medical retina was a kind of bridge to uveitis. And I think there is many connection between these two subfields of in ophthalmology, and uveitis is very exciting field in ophthalmology, we can learn a lot. We can teach, and we can help patients. And we have to be very humble and to be very active and to work hard. It is not an easy task, however, very exciting and interesting and useful for patients and colleagues.
That's true, but sometimes quite depressive. Sometimes.
Yes.
So tell me, how is your day in Ramadan? I mean, is it the usual day? Is it easy going? I mean, you work as usual. Some people take Ramadan kida as a vacation.
We try to work as usual in Ramadan, but the first days are just somewhat hard for us. But we try to organize our work. It is a bit different from other periods of the year. However, we have a lot of works even in Ramadan. We enjoy the...
Yeah. So Ramadan is work as usual, but
yes,
but maybe a little bit with some modifications. I know that you travel a lot. I know that you're a very active traveler. I mean, which country did you like most?
Tunisia and Egypt. I have been in many countries, almost all continents, and many times in US and Asia and Europe, Middle East, North Africa, and usually very happy to meet colleagues from different parts of the world to share my experience with young and old colleagues, and I'm very happy to have this opportunity to share our thoughts. And I think in uveitis it is very important to have a global approach and a global perspective. And because we can learn a lot from people from other countries, and we can also give our experience, and the profile of uveitis may have some similarities and differences, distinct features among countries, among geographic area. It is important to have a global approach. We have to, I think, to think globally and work locally in uveitis.
That's true. I think we're very lucky and privileged that we're able to travel and meet our colleagues and mix with them, learn from them, pass our information, exchange ideas, exchange knowledge. This is a blessing.
Yes.
This is actually a blessing, yeah. Okay, the last question in our social part will be, I mean, which is your preferred dish in Ramadan?
I have many preferred. I don't know if this dish is maybe dishes with fishes.
Fish.
Yeah, fish. Yes.
You like fish in Ramadan?
Yes, I like fish. Yes. Not only in Ramadan.
Okay. You like fish as a whole.
Yes.
But you eat fish even in Ramadan.
Yes, of course.
Okay, great. So thank you very much. We now know all about the social part and all about Dr. منصف and how his beginnings and how he thinks and what he likes and ودلوقتي هنصل إلى نهاية الجزء الأول من البرنامج النهاردة وفاصل ونعود. اهلا بيكم بعد الفاصل في الجزء الثاني من برنامجنا رمضان ديلي ريسيبي ريتنا ريسيبي، ومعانا ضيفنا العزيز الصديق العزيز دكتور منصف خيرالله اللي هيقدم لنا وصفته السحريه في علاج مرض Behcet's uveitis, which is one of the nastiest uveitic entities which we face every day, and it's very well known that our region is one of the regions where we meet a lot of Behcet's patients. تفضل دكتور منصف.
Thank you very much. Once again, I'm going to share with you three cases of Behcet uveitis. The first patient is a 70-year-old male with unremarkable past medical history, presenting with blurred vision in the right eye. The visual acuity was 20/40 in the right eye and 20/25 in the left eye. And slit lamp examination showed a quiet anterior chamber and one plus vitreous cells in both eyes. As you can see, fundus examination and imaging showed occlusive retinal vasculitis in both eyes associated with the retinal infiltratus and macular edema. Our etiologic workup was negative. So, in the presence of occlusive retinal vasculitis associated with superficial retinal infiltratus, with a negative workup for infectious and non-infectious causes of retinal vasculitis, a diagnosis of isolated Behcet uveitis was made based on the typical ocular findings and in the absence of any systemic manifestation of Behcet uveitis. The patient was treated with systemic corticosteroids associated with immune suppressive drug, azathioprine, associated with cyclosporine A, and then switching to biologics, adalimumab, every 2 weeks. We also did sectoral retinal photocoagulation to peripheral area of retinal capillary non-perfusion. So we all know that a diagnosis of Behcet disease is usually based on the association of ocular and extraocular findings, and there are two important classifications for Behcet disease, including the international study group for Behcet disease diagnostic criteria and the new diagnostic criteria for Behcet disease. However, it is very important to keep in mind that early diagnosis of Behcet disease uveitis either associated with extraocular manifestation or without associated extraocular Behcet disease manifestation. And in the absence of extraocular Behcet disease manifestation, we call it isolated ocular Behcet disease, which can occur in up to 15% of cases. And this early diagnosis is essential for early appropriate treatment to prevent blindness. This diagnosis of Behcet disease uveitis can be made based on the ethnic geographic background, the young age, the male gender, bilateral, acute, recurrent panuveitis or posterior uveitis, after excluding other infectious and non-infectious causes of uveitis. What are the diagnostic clues for Behcet disease uveitis? Non-granulomatous anterior uveitis, mobile hypopion with a white or hot eye in contrast to HLA-B27 anterior uveitis, the presence of a granulomatous anterior uveitis can exclude a diagnosis of Behcet disease uveitis. The second important feature in Behcet disease uveitis is the presence of diffuse severe vitritis associated with the typical vitreous pearl-like precipitatus that should be differentiated from the snowballs seen in intermediate uveitis and pars planitis. Occlusive retinal vasculitis with diffuse fur-like capillaritis, superficial transient retinal infiltratus. These are the clues for a diagnosis of Behcet disease uveitis, even in the absence of extraocular manifestations. And choroiditis is another exclusion criterion for Behcet disease uveitis. Regarding the management of Behcet disease uveitis, the presence of isolated anterior uveitis, which is a rare form of Behcet disease uveitis, we can treat patients with topical corticosteroids alone. However, the use of systemic immune suppressive drugs is indicated if associated poor prognostic factors, including young age, male gender, and early disease onset. Mild to moderate involvement of the posterior segment, systemic corticosteroids, never alone, should be associated with conventional immune suppressive agents, and biologics are used in refractory cases and sometimes as first-line therapy. If the patient presents with severe involvement of the posterior segment, the use of biologics and mainly anti-TNF-alpha agents is recommended as a first-line therapy in Behcet uveitis. Let's move to the second case. This is a 37-year-old patient with unremarkable past medical history, blurred vision on the left eye, best corrected visual acuity, 20/20 and 20/200 in left eye, slit lamp examination normal. As you can see, a normal fundus examination and fluorescein angiography in the right eye. And you can see the presence in the left eye of optic disc edema with overlying vitreous exudate, and OCT of the optic nerve head showed a mushroom-shaped hyperreflectivity, papillary hyperreflectivity corresponding to the vitreous exudate seen clinically. And there was no evidence of retinal vasculitis or retinal infiltrates elsewhere in the fundus. In this patient, a diagnosis of toxoplasmic retinochoroiditis was made based on a positive toxoplasmosis serology and a negative workup for all infectious and non-infectious causes of neoretinitis and retinochoroiditis, and the patient was treated with anti-toxoplasmosis drugs. And after treatment, 4 weeks after treatment, you can see the resolution of acute inflammatory changes with resolution of the papillary vitreous exudates. However, 1 year later, the similar neuroretinitis with the prepapillary vitreous exudate developed in the right eye in this patient, and the left eye, as you can see, showed a mild optic disc pallor with retinal nerve fiber defects. And at that time, features of Behcet disease could be found, and after ruling infectious causes of uveitis, a definitive diagnosis of Behcet disease was made and the patient was treated with corticosteroids and with immune suppressive drugs. And you can see the gradual resolution of the prepapillary vitreous exudates and the improvement in of visual acuity in this patient. So inflammatory prepapillary hyperreflective mushroom-shaped vitreous exudates is a rare but highly suggestive finding in Behcet disease uveitis. And this case showed that bilateral sequential PAVE indicative of severe neuroretinitis can occur before other ocular and systemic manifestations of Behcet disease become evident, and this may lead to mistakes in diagnosis and management. Let's move to the third last cases. The 22-year-old male, history of Behcet disease, blurred vision in the left eye with the presence of vitreous cells in both eye, mainly in the left eye. And as you can see, this patient exhibited bilateral occlusive retinal vasculitis with macular edema associated with serous retinal detachment in both eyes, and treatment including associating corticosteroids and immune suppressive drug was given to the patient. And 2 weeks later, you can see the exacerbation of the serous retinal detachment in the right eye and the resolution of the serous retinal detachment in the left eye, and the exacerbation of the serous retinal in the right eye allowed us to make a diagnosis of central serous chorioretinopathy, probably induced and exacerbated by corticosteroids, while the serous retinal detachment in the left eye resolved following corticosteroid treatment because it was inflammatory in nature. So it is very important in a patient with Behcet uveitis to pay attention to atypical features, and the central serous chorioretinopathy can occur in patients with the Behcet disease uveitis treated with corticosteroids. And it is important not to confuse central serous chorioretinopathy with inflammatory serous retinal detachment. And we did laser photocoagulation to the leaking point, gradual tapering of corticosteroids, and introduction of biologics. And you can see the resolution of the serous retinal detachment and the improvement of visual acuity.
Thank you very much, Dr. منصف, for these very interesting and highlighting the problems we face with Behcet's disease, which is a very nasty entity, I must say again, and we face a lot of problems and a lot of challenges. I like very much the algorithm which you presented, and let me ask you again, what are the criteria which you really rely upon to diagnose isolated ocular Behcet's, because this is very important.
Yes, thank you for the question. This is very important, as I said before. 10 to 15% of Behcet cases will present with isolated ocular involvement, and we should be able to make a diagnosis even in the absence of extraocular manifestation. Behcet uveitis is typically panuveitis or posterior uveitis. Isolated anterior uveitis is very rare, maybe less than 5% of cases. The clues for the diagnosis of Behcet disease uveitis include non-granulomatous anterior uveitis. If the anterior uveitis is granulomatous in nature, this can exclude a diagnosis of Behcet disease uveitis, even if in the presence of extraocular manifestation of Behcet disease. Hypopion uveitis, there are some characteristics for hypopion uveitis in Behcet uveitis as compared to HLA B25 Behcet to B25 uveitis. This is a mobile hypopion with the eye is not very hot. You can have a white eye or moderate or mild hyperemia. Diffuse vitritis is a constant feature in Behcet uveitis. The presence of pearl-like, inferior pearl-like vitreous precipitates that should be differentiated. This is very important from the snowballs seen in intermediate uveitis. And I think it is easy to differentiate pearl-like precipitates from snowballs. This is a very important features. Occlusive retinal vasculitis, and in our setting in North Africa and the Middle East, the presence of occlusive vasculitis, we should think about Behcet uveitis or tuberculosis. These are the main causes of occlusive retinal vasculitis. So Behcet uveitis is a major cause of occlusive retinal vasculitis, occlusive periphlagitis. Transient retinal infiltrates. This is another important feature of Behcet disease uveitis. And the fur-like capillarites on fluorescein angiography is typical for Behcet uveitis. However, it may also occur in some cases of intermediate uveitis and particularly pars planitis. And there are another important excluding criterion for Behcet uveitis is choroiditis. If you have choroiditis, this is not a Behcet disease uveitis.
Yes, thank you very much. Excellent. I have a question, again, another question. Will your treatment strategy, Dr. منصف, change if you have a single-eyed patient who had lost one eye from Behcet? I mean, do you, in this case, do you follow a more aggressive approach? Do you start by biologics, for example, in single-eyed patients?
Yes, of course. Biologics can be used as first-line therapy for all Behcet cases, but we have some difficulties with biologics due to costs and to health authority regulations. In a patient who already lost an eye due to Behcet disease uveitis, we have to start with biologics, even if the ocular involvement is mild or moderate.
Another question. I mean, do you think the presentations of ocular Behcets in males is different from females?
I don't think so. However, females tend to have milder intraocular inflammation, but in general, females or male have the same ocular feature. I guess so.
I mean, another point is, I'm sure you have seen, but do you think that some members you might have Behcet's disease?
Our patient, but this is a very small subset of our patient.
Right. And the last question in our scientific session for you, do you think that we're managing Behcet's disease or Behcet's uveitis much better now than before?
Of course. The rate of blindness in the 70s was about 50 or 75% of patients. between the 19 and 2000, there was an improvement in visual prognosis due to the early use of immune suppressive drugs, and with the use of biologics, the prognosis is better. However, 20 to 25% of patients still have a poor visual outcome despite the use of biologics. So we need more new drugs and more effective approach to severe Behcet uveitis cases,
or more aggressive approach in some cases, maybe to try as much as possible to save the patient's vision. Thank you very much, Dr. منصف, for an excellent review and cases. And this very nasty disease, do you think it's under control?
Yes, yes, but I think there are some unmet needs on the matter. We have to work hard to better diagnose, and I think the diagnosis of isolated ocular disease is an important step in the early diagnosis of Behcet uveitis to treat early to prevent blindness in these patients.
So now we'll ask Dr. منصف to present his recipe to manage Behcet's disease and to give us الوصفة السحرية للتعامل مع Behcet's. Please, we are all waiting for your recipe.
Yeah, thank you. This is my recipe, and my recipe is a summary of the most important. Behcet disease is a very important cause of uveitis in the Middle East and North Africa, and therefore must be considered in the differential diagnosis of recurrent non-granulomatous uveitis involving the posterior segment, and especially in young patients. Early diagnosis can be made, as I said, even in the absence of extraocular manifestation, and this is very important and crucial for treatment and prognosis. And let me remind you the clinical clues for the diagnosis of Behcet disease uveitis: hypopion uveitis, diffuse vitritis with pearl-like precipitates, retinal infiltrates, occlusive vasculitis, and fur-like capillary leakage. This is of utmost importance for early initiation of appropriate treatment to save vision, systemic corticosteroids, but never alone. Immune suppressive drugs, azathioprine and cyclosporine A, and an anti-TNF-alpha agent as second or first line therapy. This is my recipe. Thank you very much.
Well, thank you very much, Dr. منصف, for the nice recipe, a full recipe. I will follow that for sure. I'll ask you to give a final advice to young ophthalmologists interested to go into the field of uveitis.
Thank you. I think the most important advice I would give to young ophthalmologists interested in uveitis is to be clinician. Clinical examination is the most important step in the approach to uveitis, and the good clinical sense and careful clinical examination, careful history taking provide us a lot of useful and relevant information to help us in the diagnostic approach to uveitis, and we can have a diagnosis and to treat properly if we are a good clinician. So it's important to be a good clinician and to use properly imaging and properly laboratory investigation, and we have to follow a tailored approach and our laboratory investigation should be oriented by clinical findings and results of imaging modalities. This is very important to succeed in the approach to uveitis.
It's a long way, I tell you. It's a long way, but thank you very, very much, Dr. منصف, for this superb interview and superb review of Behcet's disease. كل سنة وانت طيب، وكل سنة وانتم طيبين محبي الشبكية والجسم الزجاجي وأعضاء جمعية الشبكية وكل من ما هو معنا. رمضان كريم وكل سنة وانتم طيبين ونشوفكم دايما على خير.
شكرا. It was my pleasure and see you soon. Thank you very much.
إن شاء الله.